we do practical research that helps people like you and your family stay healthy. For almost 30 years, I was blessed to work with a stellar research team. We accomplished together what none of us could have done individually. By practical, I mean we look for ways of improving people's everyday lives, like improving care for depression. This gentleman was depressed for 2 years, demoralized, not doing very much, until he was enrolled in the IMPACT trial. And by the flip of a coin, he ended up in the intervention group. And you can look at him here. This was from a story he gave for the Seattle Times. It transformed his life. And our work was motivated by the idea that whether people get the most effective depression care possible in practice shouldn't be determined by the flip of a coin. It should be reliable. We identified key elements of effective care, which we called collaborative care for depression, active follow-up, treatment monitoring, treatment modified as needed to optimize response, which we now call treat to target, patient activation and self-management support, specialist consultation readily available when needed. We didn't invent each of these things, but we learned how to put it together in ways that could make a difference for the lives of patients. We evaluated and worked on patient-centered care before it was hip. Our care managers were like bulldogs. They relentlessly followed patients to optimize their outcomes. And they were like a swarm of puppies around our patients, giving them the support and care that they needed to learn how to manage their illness. We wore the chronic care model on our sleeves from the beginning. In 1997, we gave a symposium at the National Institute of Mental Health that was talking about the application of principles of effective chronic disease care to improving care for depression. And I'll tell you, most of the people did not know what we were talking about. It was very interesting. And most of the rest thought that this was something that was just relevant to HMOs, that it didn't have broader applicability, and we were sort of kind of talking about HMO stuff, and they thought it was interesting, but it only applied in Seattle and other integrated care systems. They were in for a surprise. Our randomized trials changed concepts of effective care, and not only for depressed patients, but for multi-condition chronic disease patients. This series of randomized trials really redefined the principles of what effective depression care is. And you may notice that one of those trials, the one that Greg was involved in, was in a low-income population in clinics in Santiago, Chile. And another also that Greg was involved in was done with lay health counselors in Goa, India. So when you get back on your reviews that group health research may not be generalizable because of our population or our delivery system, we have evidence to the contrary. When I came to group health, the paradigm for improving care in depression, improving care for mental health in primary care settings was screening. So the idea was, if we just recognized people that they were depressed, ipso facto, they're going to get better. This belief was in the face of considerable evidence from screening trials that it didn't work. So From the outset of our work, we tackled this idea. We started arguing screening alone is not sufficient. Our research guided a series of major randomized trials and then large-scale dissemination initiatives. So the first generation trials conducted here and a few other places took place over a 15-year period from 1990 to 2005, and that led to second generation trials, larger, more ambitious, that took place from 1995 to 2010, and now we're in the third generation of large-scale, sometimes national or statewide dissemination initiatives that all started from research conducted right here in group health clinics. Our telephone care management work spawned innovative interventions to enhance access to effective treatment. So at one point, I don't think it's true now, but it was true a few years ago, we conducted a vet and Greg conducted the largest randomized trial of psychotherapy ever conducted anywhere. And the techniques of doing that over the telephone spawned work in applying those techniques in other special populations, in Spanish populations, in the workplace, and to people with chronic conditions, for instance. So now we've come full circle, because we started out challenging the idea that screening alone could make a difference. And now, based on 69 randomized trials, many of them conducted here, but many more conducted in other places, in 2012, the U.S. Preventive Services Task Force concluded that collaborative care justifies routine depression screening. In the systematic review that supported that conclusion, they said collaborative care models are effective in achieving clinically meaningful improvements in depression outcomes and public health benefits in a wide range of populations, settings, and organizations. In 2007, NIMH concluded it would not fund more collaborative care trials, given overwhelming evidence of its effectiveness. So what do we do now? Have we worked ourselves out of a job? Not to worry. Depression treatment, unfortunately, still achieves only a fraction of its potential benefits. And we still have lots of great ideas. But let me, as an aside, let me tell you something about being innovative. You see here the reviews of the team care trial, the multi-condition collaborative care trial that was published in the New England Journal of Medicine about a year and a half ago. The review panel was split and could not reach consensus on this application. Fortunately, the proponents for that application carried a little more weight in their argument than the people that were opposed. We got a 9.2 percentile score. In the current funding climate, if you had a split among reviewers, and for that matter, even if you had a 9.2 percentile score, you would not be funded. So we're in a very different situation, and I don't know what the implications of it are, but we're going to have to think about this very carefully, because if you're really doing innovative things, it often does not lead to consensus that you're doing the right thing. It leads people to be uncertain. Going forward, our goal is to develop care-based evidence that destroys boundaries between research and practice. We want routine care to seamlessly contribute to and draw on mass data and on patient preferences, treatments, and outcomes. We want to test personalized collaborative care that integrates general principles of effective practice while personalizing choice of treatments. We want to optimize treat to target, by accelerating the pace of reliability of discovery of treatment failures. We don't know how to predict which treatments are going to work for which patients. Treatment matching. No evidence that it works. Maybe it will someday, but right now we don't know how to do treatment matching. What we think we can do is accelerate the rate at which we find out that the treatment that a patient is getting is not working and move them on to a different treatment that may be more effective. We want to conduct continuous real-time comparative effectiveness studies using routinely collected data on treatments and outcomes. And we want to organize key elements of chronic illness care for mental and physical disorders that enhance clinician and patient capabilities to optimize patient outcomes while driving down healthcare costs. We'd like to bring patient-clinician communication to warp speed through these really way out there next-gen technologies like email, cell phones, and Epic. The technologies that we have in our hands right now can revolutionize care, and we just aren't taking advantage of them fully. A challenge ahead. Can we continue to set the pace for 21st century innovation and research with a broken 20th century funding model? I think we need to learn to continue to have the same success we've had through writing grants. We've got to learn how to strengthen our relationships with diverse stakeholders, locally and nationally, develop new skills in securing resources from supporters and stakeholders, and build a research institute endowment to support innovation and dissemination. So looking forward, the opportunities have never been better. We now have a 30-year track record to build on, and I'm really excited about the future. So thank you very much.